Good afternoon. Welcome to WICC. Myself Dr. Charan Lanjewar, Professor of Cardiology at KIM Hospital. I am very thankful to Dr. Mahapatra, Organizing Secretary, for inviting me for having a talk on acute heart failure management, what we are after the REVIVE study. So, as far as REVIVE study is concerned, the background was whether the PCI will help us to improve the LV function in those patients, comparing the optimal medical management in acute heart failure patients. Depending on around 700 patients were included in that trial, equally between the placebo and the between the OMT and the PCI arm, and we found that as a primary outcome there was equal incidence of death or mortality as well as the heart failure admissions. So, there was no much significant as a primary outcome in those patients. If you see the secondary outcome, which was the LV function and the quality of life, the quality of life improved by 6 months, but over the period of 2 years it again nullifies. So, if you see the results of conclusion of the REVIVE study, whether the PCI or the optimal medical therapy is better, both are equivalent, and it is found that PCI is not better than the optimal medical therapy in those patients. However, if you compare this REVIVE study with the STITCH trial and other studies, STITCH trial has shown the significant benefit at the 10-year follow-up with the CABG arm. So, what point to be taken from these studies? Most importantly, I think we will have to wait for about 8 to 10 long-term follow-up of a REVIVE study to talk about whether the PCI is better in those cases. It is very premature at the age of just at the 2 years to decide about which is the best therapy. We will have to wait for few years to conclude what it will be the best. Another important thing is in the REVIVE study, the class 3 and class 4 patients were only 25% patients, 75% patients were class 1 and class 2. Again, the left main and the ACS patients were not included in that study. So, that is a caveat of REVIVE study. So, that was one aspect. Considering the recent modification in the therapy and having a better hardware and cheap scenarios, the complex anatomies, we are coming up with the MCS, that is mechanical circulatory support devices in the PCI. So, with like LVAD or Impella device, the results are being better, but again we will have to wait for the major trials or RCTs trials like PROTECT 4 study, which will talk about whether the LVAD or Impella is better in those scenarios along with the PCI. Another thing, the changing advancement in the therapy like a stent modification with the thin stent studs, also the result could be better in the multivessel PCI in acute heart failure situation. So, my advice on the acute heart failure patients is, first of all, we will have to stabilize the patient by 4 armamentarium, that is the beta blockers, then we have the SGLT2 inhibitors, ARNI, and then aldactone or spironolactone. So, after getting stabilized the patient, you decide whether the patient needs the invasive versus non-invasive modalities for imaging. Once you can select the non-invasive imaging modalities better, once is there evidence of any ischemia or viability, then you can go for invasive angiography and revascularization percutaneously in those patients. If the surgeon feels that there is a high perioperative risk or surgical risk is high, in those patients again PCI can be a better option in those selected group of patients. So, in a take home messages, I have 3-4 messages. One important is after REVIVE, are you changing the treatment modalities? I will say partially yes. You can go for the multivessel PCI in few patients, selected group of patients where there is a high perioperative risk as far as CABG is concerned. Another thing is viability and the stress imaging is not mandatory in all patients, but they should be undertaken in the selected group of patients to have the better management. And third, we will have to take incorporation of mechanical circulatory support devices in those patients, because they are a complex anatomy having LV dysfunction and other coexistent valvular problems. So, in the future where the trials are upgoing, so those once the results of those PROTECT and the devices trials is there, we will be able to answer those queries. So, thank you very much, and thank you very much Dr. Mahapatra for inviting for the lecture.